Let's start. طيب, which nervous system is responsible for the pupil dilation? Sympathetic. And pupil constriction? Parasympathetic. Excellent. طيب, in this lecture, we will discuss the sympathetic disorders and the differential diagnosis and the parasympathetic disorders. Okay. So, first, let's discuss the pupillary light reflex. تمام. When the light comes to the eye, it's absorbed by the photoreceptors, and then it goes through the retinal nerve fiber layers to the optic nerve, okay? And then it goes to the chiasm. Normally, when you want to see, it goes from the chiasm to the lateral geniculate nucleus here. But the pupillary light reflex is different. It bypasses the lateral geniculate nucleus and goes directly to the midbrain at the pretectal nucleus, exactly at the dorsal part of the midbrain. And from there, two fibers goes to the third nerve nucleus, more specifically the Eddingville-Westphal nucleus. And then the efferent pathway starts from there, mainly the parasympathetic nervous system. So it goes here through until it reaches the ciliary ganglion, and then from there, the short posterior ciliary nerve goes to the pupillary constrictor muscle, and then you will have bilateral constrictions because of this bifurcation. Clear? So whenever you shine the light in one eye, you should expect both eyes to be constricted. You need to understand this to understand the afferent pathway problem. So pupil disorders can be of an afferent problem or an efferent problem. Afferent problem will manifest as a relative afferent pupillary defect, which indicates a unilateral optic neuropathy or a bilateral but asymmetric worse in one eye. So normally when you shine the light here, both pupils should constrict, but when you move to the other eye, both pupils dilate. This means there is an afferent pupillary defect here. Clear? طيب. What are the other causes of relative afferent pupillary defect other than optic neuropathy, you know? If there is a severe retinal damage, okay, because the retina is part of the... What else? Cataract, white cataract, dense cataract with light perception? No. Excellent. Could you have a relative afferent pupillary defect with totally normal visual function? No. It's not pharmacologic dilated. It's going to be fixed dilated. When you shine the light to that eye, the other eye should constrict. So this is not a relative afferent pupillary defect. My question, could you have relative afferent pupillary defect without any vision problem? Yes, in rare cases. It's mentioned here, tectal RAPD. When there is a problem here in the midbrain, mainly in the pretectal nucleus, because the pretectal nucleus is part of the pupillary light reflex. So when you have a lesion here, you might have a contralateral relative afferent pupillary defect with normal visual function. Clear? Good. You understand the tectal relative afferent pupillary defect, huh? Good. طيب. Now let's move to the... طبعا we will not discuss the afferent problem because it's outside the scope of this lecture. We're talking about different kinds of optic neuropathy. But now let's focus on the efferent problem. So we mentioned earlier that the sympathetic nervous system is responsible for the pupil dilation. All right? If you have a problem in the sympathetic nervous system, you will have myotic but reactive pupil. When you have a problem in the parasympathetic nervous system, you're going to have dilated but fixed dilated non-reactive pupil. Okay? And the reason behind that is here. You will not have, if you have an efferent problem, you will not have any reaction from the light. So sympathetic nervous system, we will discuss it in the following slides and its pathway and the parasympathetic nervous system, mainly the third nerve, or disorders of the ciliary ganglion. We name it as tonic pupil. Clear? طيب, let's move. 25-year-old female presented with unequal pupil. The question is now, which eye is the abnormal one? Right eye? طيب, do you think looking at the pupil in dark and light is so practical? It's good if you measure it, but sometimes it makes you confused. Which one is greater in dark? Which one is greater in light? Especially if you are in the clinic, you're seeing patient, anisocoria. So which problem is this? Is this sympathetic? Is this Horner? Is it tonic? Which one is worse in dark? Which one is worse in light? Sometimes you can be confused in the clinic, okay? So I will tell you an easier way to differentiate. طيب. So it could be of a parasympathetic problem, like from the brain, third nerve, or ciliary ganglion, or tonic pupil. Or it could be from the sympathetic chain, brain, neck, or upper chest problem. Or it could be other causes, like iris disease, from surgery, trauma, uveitis, leading to pseudosciatica, or topical drops. You have to look at these differential in your history and examination. Or it could be physiologic in 20% of the cases, if 20% of normal patients can have physiologic anisocoria. طيب, what if I tell you the left eye is the problem, is the abnormal one? طيب, again, it could be physiologic when the difference is less than 1 millimeter between two eyes and the pupil is reactive and the size of the pupil is the same in dark and light and no other ocular or neurological problem, no ptosis and full extraocular motility. If the dilated pupil is the problematic one, could be of a third nerve, tonic pupil, pharmacologic, or from trauma. Have you seen cases of dilated pupil after trauma or after surgery? Yes. What do you call that if it's after PKP? It's a value. Okay, good, excellent. Or if the myotic pupil is the problematic one, could be Horner, pharmacologic, from uveitis, or Argyro-Watson pupil, mainly from syphilis, or it's from long-standing Aedes pupil. In the history, you need to ask about the onset of the anisocoria. When did the patient notice that? Is it since birth or 1 day, 2 days? What are the associated symptoms? Is there any blurred vision or field loss, which might point toward the orbital apex, where the optic nerve is there, third nerve, and the sympathetic nervous system is there? Is there any history of transient visual loss, which could be from ICA dissection, internal carotid artery dissection? You need to ask about history of trauma, car accident, like chiropractor manipulation. Some patients go to some chiropractor extending their necks. So this might put them at risk of ICA dissection, and the patient can present with only Horner syndrome. GCA symptoms, if the patient more than 50, any patient who's more than 50, make it a habit to ask about GCA symptoms, especially with neuroophthalmic conditions. Ask about the pain, if there is any pain in the head, neck, or chest. Any neurological symptoms, headache, numbness, weakness, problem with the balance. Ocular history is very important. If the anisocoria was noted immediately after surgery, then you can clearly diagnose the patient. Or is there any trauma to the eye? And then past medical history and surgical history, history of cancer, metastasis, topical agent. Is there any neck trauma or neck surgery, radiation to the neck? And then you ask about the medication. Certain medication can cause bilateral dilated pupil or constricted pupil. In the exam, again, I repeated the same slide that we presented last week. You have to do full neuroophthalmic evaluation for any patient. Don't just look at the pupil. You need to check everything. طيب, how would you approach? So which one is abnormal? Somebody said this one is abnormal one, okay? I say this is the abnormal one. Okay, so how can you differentiate? check the pupil reaction to the light, and that's it. When the pupil is reactive to the light, then the meiotic problem is the abnormal one. If the pupil does not react to the light, then the dilated pupil is the abnormal one. Clear? You understand why, right? Because of the parasympathetic nervous system is involved in the pupillary light reflex. So if this pupil does not react, then this is the problem one. If it reacts and this one reacts, then this is the abnormal one. So we shine the light here, it reacts. We shine the light here, it reacts. Then the abnormal one is here. Now you can check which eye is abnormal, at what stage or at what state the anisocoria is worse. Is it in the dark or the light? If it's worse in the dark, خلاص, this is the abnormal one. Okay? But the light reaction is simple, easier way to differentiate. And then look for, if the meiotic problem is the abnormal one, look for signs of Horner. Okay, like ptosis, mild ptosis, or there is dilation lag of the affected pupil in the dark. Okay, if there is ptosis and the anisocoria is worse in dark, then it's likely to be Horner. Then you can do the drop test to confirm the diagnosis of Horner. Clear now? Clear this part? طيب. If there is no ptosis and the anisocoria is the same in light and dark, you apply the pharmacologic testing, it's negative, then it's likely to be physiologic. طبعا everything after we exclude other causes like medication, like uveitis, trauma, etc. by doing slit lamp exam. طيب, this eye is meiotic and you have mild ptosis. صح? You agree? So this is Horner. So this eye is normal. طيب, what is Horner? Horner syndrome results from a lesion in the oculosympathetic pathway that is characterized by ipsilateral ptosis in both upper and lower lid. It's usually mild. And meiosis and anhidrosis, either hemifacial or in the forehead. If you see iris heterochromia, then it's likely to be congenital. How can you diagnose Horner? Any suggestion? I mean, how to confirm the diagnosis of Horner? By doing pharmacologic testing. Which pharmacologic testing you do? Cocaine? Good. في cocaine هنا في كيكش؟ تمام, good, excellent. طيب, just for the sake of the lecture, it's not practical, but cocaine test can be done. It's cocaine 10%. It blocked the reuptake of the norepinephrine at the sympathetic nerve terminal. And because there is no norepinephrine, in patients with Horner syndrome, you will see nothing. But normally, if you apply cocaine to any normal patient, the pupil dilates. تمام? What we have is the apraclonidine. Okay, I think it's available at Kekish now. It's weak alpha-1 adrenergic agonist. Normally, if you apply apraclonidine to any normal patient, you will not see any dilation. But in Horner, the pupil dilates due to denervation hypersensitivity. I'm sure you have this in other lectures. You have to avoid. It should be avoided in children due to the CNS and respiratory depression. Good. طيب. Before going to the etiology, the causes of Horner can be classified based on the anatomical location or based on the etiology. I mean pathogenesis. طيب. Let's understand the sympathetic pathway. It starts from the hypothalamus. طيب. It goes down through the brainstem, mainly the dorsal part of the brainstem, and then to the spinal cord until it reaches the level of C8 to T2. طيب. And then the second order neurons start from here. It exits the spinal cord, travel at the cervical sympathetic chain through the brachial plexus. Okay. and then over the pulmonary apex here. All right, so if you have any problem in the lung here, it might cause Horner. And then it goes to the superior cervical ganglion at the bifurcation of the common carotid artery. All right, here at the angle of the jaw. This is the second order neuron. And from there, the third order neuron starts. So anything prior to this is called preganglionic. Anything after the superior cervical ganglion is called postganglionic. طيب. And the third order neuron goes along the internal carotid artery. So if you have an ICA dissection, you will have Horner syndrome, or you might have Horner syndrome. And then it goes to the cavernous sinus, and then enter the orbit and join the first division of the trigeminal nerve, and then it goes to the pupil. طيب. So cavernous sinus has, third, fourth, V1, V2, and sixth nerve in addition to the sympathetic nerve. طيب. So the sympathetic pathway is in the head, neck, upper chest. All right. طيب. First order neuron, either you have a brainstem stroke, tumor, spinal cord problem, demyelinating disease, or cervical spondylosis. Second order, you might have a tumor in the lung or thyroid, ICA dissection, or can be iatrogenic from any surgery here in this area. The third order neuron, it's either from the internal carotid artery like dissection, cavernous sinus tumor, or inflammation, or patient can have certain type of headache, can present with picture of Horner like cluster headache, and it's called trigeminal autonomic cephalgia. And cluster headache is one type of this trigeminal autonomic cephalgia. Around 1/3 of the cases are idiopathic. Clear? So if you understand the pathway of the Horner, you will understand the workup. How would you work up the patient? So you need to image the whole pathway, starting from brain, neck, and the upper chest. Okay, MRI and MR angio. Clear? Because the sympathetic pathway, you can see it's really in close to the artery, especially the internal carotid artery. طيب. Another classification is based on the pathogenesis or the etiology of like malignant tumor. You can name any malignant tumor, benign tumors, you can name them. Neurologic problem like stroke, demyelination, vascular problem like cluster headache, GCA, dissection, infectious etiologies, or iatrogenic from any procedure affecting this long pathway from the head, neck, upper chest. Or it can be from trauma. And in those cases, you need to rule out ICA dissection. I repeated ICA dissection so many times because it's real emergency. I get this from iWiki, so you can go back to iWiki and find these differential. طيب. Localization, you can do the hydroxyamphetamine test 1%, which is not readily available. Again, the same as cocaine test. It can differentiate preganglionic from postganglionic. Again, this is textbook, not practical, because it's mentioned in the textbook that postganglionic is benign, preganglionic is malignant or severe, but this is not correct. ICA dissection is postganglionic, and it's real emergency. So it enhances the release of norepinephrine from preganglionic nerve. In preganglionic Horner syndrome, you will have dilation. If it's postganglionic, no dilation. Again, this is not practical. You need to image the whole tract. You need to take history from the patient and exam also. You can ask your neurology colleague to examine the patient, examine the neurological system. If the patient is having ataxia, nystagmus, hemisensory loss, this might suggest a problem in the medulla. If the patient is having fourth nerve, this might point toward the midbrain. If the patient is having Sixth nerve, this might point toward the sixth nerve nucleus. If the patient is having cough, hemoptysis, it might be tumor in the chest, pancreas tumor. If the patient post RTA with pain in the neck, amaurosis, I mean transient visual loss, you have to rule out ICA dissection. If the patient is having headache, recurrent headaches associated with conjunctival tearing, rhinorrhea, this might be cluster headache, okay? This is from your American Academy book. You can go back to your book and find this table. طيب, clear Horner? Easy, difficult, midway? Do you learn something new? طيب. Important to recognize Horner, to differentiate which pupil is the abnormal one, is the small one or the large one. You know how to approach. You know the apraclonidian test. The patient is going to have dilation if it's Horner. You know how to work up the patient. Okay? That's the most important thing in your emergency and your real practice. طيب. What if you shine the pupil to one eye and it's fixed dilated? Then this is the abnormal one. Okay? Look for history of trauma, surgery, do slit lamp examination. If you see signs of trauma, it's likely to be traumatic. If you don't see any signs of trauma and no previous surgery, then look for ptosis, look for the extraocular motility. If there is diplopia or extraocular motility limitation, or there is ptosis, then it's likely to be, or it is, what? Third nerve palsy or partial third nerve palsy. But if there is no double vision, no ptosis, just dilated pupil, tonic, not reactive, then look at the slit lamp, look at its reaction to the light. If you see spiraling of the pupil or vermiform movement, I will show you in the video, and then check for the near reaction. If it's reactive to the near, then it's likely to be tonic pupil. If you don't see anything, ask the patient about which medication are they using. Okay, maybe it's pharmacologic. طيب, let's start with tonic pupil. Normally, when you shine the light to the pupil, it constricts at one piece. Okay? Within tonic pupil, you'll have segmental vermiform movement. This part is constricted, this one is fixed. This is the light is fixed, mid-dilated. But when they see near object, the pupil constricts. And this is light near dissociation. Okay. Tonic pupil results from damage in the ciliary ganglion or the short ciliary nerve. Signs suggestive of tonic pupil, dilated pupil that is poorly reactive to the light but better reaction at near. You will see the vermiform movement of the iris or sectoral iris palsy. It constricts with diluted pilocarpine, 0.1%. Normally, the pupil should not constrict with 0.1 pilocarpine, but in patients with tonic pupil, it constricts due to denervation hypersensitivity. This is the location of the ciliary ganglion. It's located between the optic nerve and the lateral rectus. Causes include any damage to the ciliary ganglion or the short ciliary nerve, either from surgery, orbital surgery, trauma, a laser, especially PRP or cryotherapy to the retina because it affects the short ciliary nerve. Inflammation, infection from varicella zoster or ischemia. Or it can be from a systemic disease like diabetes, neurosyphilis, Guillain-Barré syndrome, mainly the Miller-Fisher variant. Could be rarely from paraneoplastic or familial dysautonomia. If the cause is idiopathic, we call it Aedes pupil. Okay, it affects young female from their 20 to 50. Most of the cases is unilateral. If the other pupil is affected, you need to rule out syphilis. Around 70% of the cases are associated with areflexia. So Aedes is for idiopathic causes, and tonic pupil is for if you know the cause. You can call it tonic pupil from such and such. But if you don't know the cause, you can say Aedes tonic pupil. طيب, can anyone describe? This is to the light, and this is at near. First, what we have here? We have anisocoria, right? This one is dilated and this one is constricted. Tamam? At the light, there is no, it's fixed dilated. So this is the abnormal one. This is at near. What you notice? Reactive to the near. So what do we call this? Light near dissociation. Differential? Okay. Okay. اسمها Arger Robertson. Okay, syphilis. Okay. Dorsal, excellent. Dorsal midbrain syndrome. What else? ليش قلت dorsal midbrain syndrome? How do you... ليش قلت dorsal midbrain syndrome? Why? Why it causes light near dissociation? Exactly. So back to our this diagram. This is the pretectal nucleus in the midbrain, in the dorsal part of the midbrain. If it's affected, then the light reaction is going to be abnormal, but the near reflex has another pathway. So the near reflex is going to be preserved, but the light reaction is going to be abnormal. Okay? Other causes include bilateral optic atrophy or third nerve palsy with aberrant regeneration. Clear? هذه it's commonly asked in board exam or clinical examination, the differential of light near dissociation or the quizzes. طيب, let's discuss the dorsal midbrain syndrome. We said that the dorsal part of the midbrain has the pretectal nucleus, which is responsible for, which is part of the pupil light reflex. If it's abnormal, then the pupil will not react to the light. All right? And other structures in the dorsal part of the midbrain is called the posterior commissure. The posterior commissure, which is responsible for the supranuclear control of the upgaze. If it's abnormal, the patient cannot look up. Okay? So we have pretectal nucleus. That's why the patient is having light near dissociation. And we have the posterior commissure. That's why the patient is having supranuclear upgaze palsy. So supranuclear upgaze paralysis is from the posterior commissure affection. And the patient is trying to look up, so the eyelid is going up. So we call this Collier sign or bilateral eyelid retraction. And when the patient is trying to look up, what happened? Co-contraction of the extraocular movement. And the patient is going to have the convergence retraction nystagmus. You see the retraction? And here is the light near dissociation. It's fixed, non-reactive. Both pupils. When they look at near, pupil constricts. So in those cases, what are you going to do? Imaging to look for any compressive lesion to the dorsal part of the midbrain. Okay? So also look for hydrocephalus, because here the cerebral aqueduct is here. So if it's dilated, it can compress the dorsal part of the midbrain. I'll look for signs of stroke, demyelination like multiple sclerosis. طيب. Is it clear the light near dissociation, the dorsal midbrain syndrome? You understand now why the patient is having supranuclear upgaze palsy and the patient is having light near dissociation, right? طيب, the question is now how to differentiate between supranuclear disorder from nuclear or infranuclear. Doll's head maneuver, excellent. It's normal in what condition? In supranuclear, palsy is normal because the doll's head maneuver is controlled by the ear, okay? And this bypasses the lesion, okay? If the patient is having, for example, 6th nerve palsy, whatever you do is still there. There is no, it's abnormal. Okay, but if the patient is having supranuclear upgaze palsy, when you do the Doll's maneuver, the eyes goes up. Okay? Excellent. اسمك؟ عبد الرحمن فرحان, which program? طيب, level R4? Okay, excellent. طيب. Let's take this case. 55-year-old gentleman referred for anisocoria that has been there for 1 day. Diagnosis. Excellent. 3rd nerve palsy. So we have here dilated pupil, ptosis. Here the examiner is trying to pull up the eyelid. And we have XT. Tamam? And the eye is going down. So as you all know, the 3rd nerve supply all the muscles, including except the lateral rectus and the superior oblique. It innervates the levator muscle and the pupillary constrictor muscle. Constrictor muscle. Causes can be of a compression from an aneurysm, ischemia, which is the most common. Or from inflammation, sarcoidosis, you can name it, MS, infectious etiologies like meningitis, infiltration, or traumatic 3rd nerve palsy. When you read about 3rd nerve in any textbook, they mention pupillary involvement or pupillary sparing 3rd nerve palsy. Tamam? Classical teaching, طبعا this is not true. In real life, this differentiation is not totally correct. طيب. So, I will just explain to you. Pupillary nerve fibers are in the periphery of the 3rd nerve. Okay? The pupillary fibers are located in the periphery of the 3rd nerve. More precisely in the medial aspect of the 3rd nerve. So if there is an external pressure from tumor or posterior communicating artery aneurysm, the pupil is going to be fixed dilated. And we say pupil involving 3rd nerve palsy. طيب. However, if you have ischemic damage, the vasa vasorum goes inside the 3rd nerve centrally. So the pupillary fiber, classically teaching, it's preserved. Okay? It's mentioned in the textbook that until proven otherwise, pupil involving 3rd is aneurysmal compression until proven otherwise. However, pupil involving 3rd nerve palsy does not always indicate compression. Around 20% of ischemic 3rd nerve palsy can present with pupil involvement. On the other hand, pupil sparing complete 3rd nerve palsy is typically احنا قلنا ischemic, but sometimes partial cranial nerve or 3rd nerve palsy with normal pupillary function are due to compressive lesion from aneurysm that may later progress into pupillary involvement. Clear؟ واضحة؟ يعني compressive lesion can present with dilated pupil or normal pupil. Also, ischemic injury can present with normal pupil or with dilated pupil in 20% of the cases. That's why in all third nerve palsy, you need to do imaging, no matter what, okay? Immediate MRI brain and orbit with contrast, in addition to MR angio or CT angio to rule out aneurysmal compression. In any patient who is more than 50, you need to rule out GCA by asking the symptoms of GCA, ordering ASR and C-reactive protein. And sometimes, based on your clinical judgment, you can do LP if you think it's infiltrative or from meningitis, by asking questions like if they have other symptoms, neck rigidity, fever, malaise, then you should suspect meningitis in those cases. طيب طبعا هذا internal carotid artery, and this is the posterior communicating artery, and this is the third nerve. You can see here the posterior communicating artery is at the medial aspect of the third nerve. احنا قلنا the pupillary fibers are located in the periphery of the third nerve, mainly at the medial aspect. طيب إذا كان في هنا compression في lateral aspect, you might have pupil sparing, but it's not totally benign. So that's why you need to do imaging, no matter what is pupil involving or not. طبعا third nerve palsy is real emergency. The mortality rates may, so it might be associated with cerebral aneurysm that may carry 50% mortality rate. هنا aneurysm become aneurysm. طيب. I think we have time to discuss this. It's going to be complicated شوي, بس try not to memorize, just understand. If you understand the anatomy of the third nerve, you will understand the etiology. طيب. احنا قلنا the third nerve here is located in the midbrain. It runs anteriorly, goes to the red nucleus, and goes to the cerebral and cerebellar peduncle, exit the midbrain anteriorly, goes between the superior cerebellar artery and the posterior cerebral artery. It runs by the posterior communicating artery, goes to the cavernous sinus, enter the orbit through the superior orbital fissure, and then innervate the extraocular muscles. Third nerve palsy can be of a nuclear cause. And the nucleus of the third nerve is a very complex structure. طيب, هنا right part of the nucleus, or the right third nerve, and this is the left third nerve. You can see the subnucleus for the levator is located in the center. So if you have a nuclear lesion, the patient is going to have bilateral ptosis. Clear? Because the levator subnuclei is located centrally. Sometimes if the patient is having nuclear lesion, the patient is going to have contralateral superior rectus weakness. Why is that? Because the superior rectus nuclei is located contralaterally. So if you see bilateral ptosis or a contralateral superior rectus weakness in a patient with third nerve palsy, this localizes to the nucleus. So when you order the MRI, tell the radiologist, please look at the midbrain. Clear? طيب. If the patient is having contralateral tremor or contralateral weakness or ipsilateral ataxia, what do you need to look at? Vesicle. Where is the vesicle? Here. Okay? Midbrain lesion. Either MS, stroke, tumor. Okay? So those are brainstem signs or symptoms. طيب. Contralateral tremor, contralateral weakness, ipsilateral ataxia. If you see these, or you ask the history and the patient or you notice that in the clinic, The patient is having third nerve with ataxia, tremor, weakness, then this is not an isolated third nerve palsy. So you need to look at these things. Clear? You do need to memorize. You can, if you see the patient clinically, it doesn't matter if it's Benedict syndrome, Weber syndrome. You know what are you dealing with. You know you are dealing with a midbrain lesion. Tamam? If the patient is having isolated, it's likely to be here in the subarachnoid space, either from compression, aneurysm, or high ICP. If you see a patient with multiple cranial nerve palsies like fourth, fifth, sixth, or Horner, this points toward cavernous sinus, exactly. طيب, what if the patient is having optic neuropathy? In addition to the fourth, fifth, sixth, or Horner? Orbital apex, exactly. Yes, it could be. It could be. But it's usually is going to be extensive. ليش؟ لأنه third nerve is located where in the midbrain? In the superior part of the midbrain, superior colliculus. And the fourth is lower in the inferior colliculus. So you need to have a large lesion causing third, fourth, and this large lesion should cause other neurological symptoms. Clear? But it could be. واضح؟ You mean it's not يعني قصدك ايش؟ Yeah. Yeah, it can be both, and you will see also other signs. طيب, usually ankle herniation is present from tumor, space occupying lesion. You will see other. The patient is going to be sick. تمام. The patient will not be present to the ophthalmologist. تمام. طيب. Can anyone describe? This is the patient looking straight forward, and this is patient looking to the left. Differential. Sorry? Up gaze, down gaze, lateral gaze, normal. We have, yes, adduction deficit. What else? Nystagmus? No. Okay, there's exotropia. There is adduction deficit. We have eyelid retraction here when the patient is looking to the left. Differential? Duane, yes. You need to ask about the history of Duane. Is it congenital or not? This is acquired. Myasthenia, one of the differential, exactly. What else? Thyroid, myositis, yes. What else? What if I tell you the patient had history of third nerve palsy? Aberrant regeneration, exactly. So this is a partial third nerve palsy with aberrant regeneration. Could this be ischemic? No. So it's from compression, either tumor or aneurysm or from trauma. So the differential, you all said it right. Myasthenia, restrictive myopathy from thyroid or myositis, Duane retraction syndrome if it's congenital, or right eye, no, internuclear ophthalmoplegia. So it can be congenital or it can be primary, meaning the patient is presenting with apparent regeneration without history of third nerve palsy. It usually results from slowly growing intracavernous lesion. If it's secondary, from trauma, surgery, aneurysm, and it's never ischemic. So you have to image those patients. This is a rare condition called intermittent unilateral pupillary mydriasis. It's typically present in young adult with history of migraine. One pupil transiently become large, and this lasts around 15 minutes. It can be of a sympathetic or a parasympathetic form. This is intermittent anisocoria. So what if the patient is having bilateral dilated or constricted pupil? It's pharmacologic until proven otherwise, okay? So if both pupils are dilated, you need to ask about the parasympathetic agents like atropine. You don't ask only about medication, ask about inhalers, patch, and also exposure to certain plants. It can be post-seizure or anxiety. When you do the 1% pyrocarbon test, it's going to be positive. The pupil constricts with the 1% pyrocarbon test. If the constricted pupil is the abnormal one, it's likely to be pharmacologic or exposure to organophosphate pesticide or narcotics, morphine intoxication, or it could be pontine hemorrhage or from sleepiness. Pontine hemorrhage will not result in only bilateral constricted pupil. The patient is going to have other neurological symptoms. This is from iWiki. You can look at it. The causes of the agent that might can cause or might cause dilation of the pupil. These include antihistamines, amphetamines used illegally or as a treatment of ADHD, cocaine, treatment for Parkinson's like the levodopa, anticonvulsant medications, or the patient is using atropine or scopolamine patches for the motion sickness. Certain plants can cause dilated pupil like the Jimson weed plants, certain lotions some patients are using that has anticholinergic property. So don't just ask about the medication, ask about cream, inhalers, or plant exposure. طيب, this is the summary of anisocoria. Look at the pupil. If it reacts to the light, the small pupil is the abnormal one. Good. If it does not react, then the large pupil is the abnormal one. And you can follow this diagram. It's from the American Academy of Ophthalmology. Any questions? Is it reactive to the light? Yeah, okay. I don't think so. What do you think? So what's the mechanism? A lot of patients are using NAFCON, okay? When you say it's a cause, you need to have like every patient is using the NAFCON, then they will have dilated pupil, okay? Yeah, it's complex mechanism. Nobody understands. I mean, there are a lot of theories behind that. It could be related to the, the hypersensitivity, the denervation hypersensitivity. But again, it's gonna be fixed, either dilated or constricted. It's not going to be reactive to the light. Maybe they hit the sphincter with the yag. If you yeah, but yeah, interesting. Yeah, I've seen cases post laser or PRP or retina surgery with fixed pupil, dilated fixed pupil. Maybe, or other causes, or it could be tonic pupil from other causes. طيب يعطيكم العافية.